antimicrobial stewardship. We have been used to talking about antibiotic stewardship, but infections can be caused by bacteria, by fungi and viruses. So, this broad term antimicrobial stewardship is nowadays being used to encompass all the infections. Now, sepsis is the biggest killer of mankind at the present moment. About 50 million people in the world are dying every year from sepsis. This is a bigger killer than cancer, heart attack and strokes taken together. WHO has declared that infection due to multi-drug resistant organism is going to be the biggest threat to mankind in the coming years. So, in this background, the importance of antibiotic and antimicrobial stewardship has become very, very important. Now, bacteria are getting increasingly resistant, more so in the Asian subcontinent. There is a high prevalence of extended spectrum beta lactamases in our country, both in the hospital and in the community. About 60 to 70% of the gram negative Enterobacteriaceae have become beta lactamase positive. Not only that, there is increasing prevalence of carbapenem resistant Acinetobacter, methicillin resistant Staph aureus and multi-drug resistant Pseudomonas. Deaths are increasingly more due to drug resistant bacteria. Asian continent has been affected mostly by this increasing resistant bacteria, and there are a lot of collateral damage of this infection. There might not be possible to do transplant surgery, chemotherapy, high risk surgery. People are living more nowadays with renal failure and liver failure, and once they get an infection with this drug resistant organism, it will be very difficult for them to survive. So, one can imagine the long lasting problems with these kind of infections. On the other hand, the antibiotic pipeline is drying out, especially for gram negative infection. There hardly been any new class of antibiotic discovered in the last 5 to 6 years against the gram negative organism. In this background, a review of antibiotic prescription in the hospital by Cochrane collaboration has surmised that about 50% of antibiotic usage in the hospital is inappropriate. And we are the enemy, and it is very important that we keep our environment clean. Antibiotics are natural resources, we should not be wasting them. So, just like an eco-friendly environment, we have to practice an eco-friendly antibiotic use. The Infectious Disease Society of America has laid down broad guidelines for usage of antibiotics in the hospital setting. Now, there are two pillars regarding the use of antibiotics. One is antibiotic stewardship and second is infection control. Infection control has been talked about in other lecture. I will be emphasizing on antimicrobial and antibiotic stewardship in this talk. Now, the objectives of my talk would be to give you an overview of the principles of antibiotic stewardship, the components of antibiotic stewardship, how to practically apply these principles at the bedside in our ICU, what are the barriers of this stewardship of antibiotic in our ICU, and what are the future directions. The principles of antibiotic stewardship program is to optimize the clinical outcome of the patient, that is to decrease mortality and morbidity, and to minimize the unintended consequences of antibiotic usage like toxicity, increasing resistance, selection of pathogenic organism and reducing the cost. Let us take an example of a 60-year-old male presenting with a feature of acute pyelonephritis. The initial antibiotic order should be prescribed according to any of these protocols. A medical officer on duty can prescribe based on his knowledge of the disease. The medical officer can call the consultant and which takes some time, and he prescribes the antibiotic depending upon the advice of the consultant, or the medical officer follows the hospital guidelines. And the last option is the medical officer follows the guidelines and prescribes an antibiotic, but an antibiotic stewardship team comes and reviews the antibiotic the next day, sits down with the resident and suggests some changes of antibiotic depending upon the previous antibiotic history. You would all agree the last option seems to be most suitable for this patient. So, what is an antibiotic stewardship team or antimicrobial stewardship team? Optimally or ideally, this team should contain infectious disease physician, clinical pharmacist with infectious disease training, clinical microbiologist, information system specialist, infection control professional, and hospital epidemiologist. But having so many human resources might not be possible in our country. So, a practical solution for an antimicrobial stewardship team could be a physician with an interest in infectious disease, a microbiologist, ideally microbiologist interested in bedside clinical medicine, infection control nurse, and a hospital administrator. We should assign a team leader who would be the director of the stewardship team, and responsibility of each member of the team should be assigned. A standard operating procedure for the program should be outlined, and an expected outcome of the program should be stated. Now, each member of the team should have an assigned role. For example, the physician, ideally with an infectious disease background, should be the director of the program. The clinical microbiologist should provide the surveillance data on antimicrobial resistance. The information system specialist is to provide the computer support necessary for the surveillance. Infection control professional and hospital epidemiologist should coordinate the efforts on improving antibiotic usage, and clinical pharmacist should be knowledgeable on the appropriate use of antimicrobials. These team members should be compensated appropriately for their time. They should obtain adequate authority from the hospital administrator. That is the key to a successful antimicrobial stewardship. There should be an adequate budgetary provision for necessary infrastructure to measure antimicrobial use and to track use on an ongoing basis. Before implementation, this program should be presented to the hospital governing board by the director, and other key players of the hospital should also be included to ensure their acceptation, support, and buy-in from all the stakeholders. It is a collaborative effort, and this collaboration should be intra-departmental and interdepartmental. The critical care and other services which consume most of the antibiotics in the hospital, the microbiology department, the hospital administrator, the quality control and safety department, pharmacy, drug and therapeutic committee, infection control committee, information technology and IT should be involved in the antimicrobial stewardship team. What are the key elements of the program? First and foremost, there should be surveillance of resistance pattern of the bacteria in the ICU and in the hospital, active monitoring of antibiotic use, and to follow the consumption of antibiotic, to foster a culture of appropriate antibiotic use in the hospital, minimize secondary spread of resistance, and to devise local strategies based on local antimicrobial use and resistant problems and on available resources. There are two kinds of strategies for antimicrobial stewardship. One are core strategy and second is supplemental strategies. There are two core strategies. The first core strategy would be, let's take an example, a 65-year-old patient with acute pyelonephritis admitted with shock late night. Now, he has to be started urgently on an antibiotic. The house officer can prescribe as an educated guess, or he calls his consultant and prescribes antibiotic of his choice, or he follows a hospital guideline, or he prescribes a broad spectrum antibiotic as per guideline, but the stewardship team comes and reviews the antibiotic and gives him suggestions. You will all agree the fourth option would be most suitable for this patient. So, the first and foremost core strategy for antimicrobial stewardship would be a prospective audit with intervention and feedback. Now, prospective audit of antimicrobial use with direct interaction and feedback to the prescriber is the key to this program. This can be done by the infectious disease physician or a clinical pharmacist with infectious disease training. This definitely reduces inappropriate use of antimicrobials in the hospital. These interventions can be communicated to prescribers either orally, verbally, or in writing. A written communication by using special non-permanent forms can be placed in the medical record or chart by the team, and they can be subsequently removed in order to decrease any hassle of medico-legal problems later after the intervention or at the time of discharge from the hospital. Each intervention by the antibiotic stewardship team provides the opportunity for the education to the provider. It has been found that using a senior member of the antimicrobial team like the physician or the clinical pharmacist has more impact on the provider than other team members. We need to identify subscribers of these antibiotics by use of computer surveillance of antimicrobial use, by looking at the pharmacy records. We should target the specific services or units like intensive care unit, surgical departments, and we should identify patients who are receiving a particular antibiotics repeatedly. The effectiveness of these programs depend upon who is making the recommendation. Recommendation from an antimicrobial management team resulted in increased antimicrobial appropriateness and increased clinical cure. Let us take the same example, a 65-year-old patient admitted with an acute pyelo. He has previously failed carbapenem therapy. The house officer wanted to start him on colistin. He writes the colistin prescription and pharmacy supplies it for 7 days, or the pharmacy can deny to give colistin till consultant signs the prescription, or pharmacy supplies the first dose and the stewardship team discusses with the clinical team for appropriateness of further prescription. So, this third policy is what is known as formulary restriction and pre-authorization requirements for specific agents or for restricted antibiotics like colistin. So, this is designed by the Pharmacy and Therapeutics Committee, which construct a hospital formulary on the basis of therapeutic efficacy, toxicity and cost, and they should limit redundant new agent with no significant additional benefit. Now, antimicrobial restriction. So, limitation of formulary of antibiotic and requirement of pre-authorization and justification is another way, a core strategy of antimicrobial stewardship. So, a prospective audit and feedback of antibiotics to the provider and having restriction on formulary and pre-authorization of some restricted antibiotics are core strategy for fulfillment of this antibiotic stewardship program. Pre-approval and restriction of broad spectrum antimicrobial led to a short term increased susceptibility among gram-negative pathogens in some studies. In response to an increasing incidence of cephalosporin resistant Klebsiella, a pre-approval policy was implemented for cephalosporins. This resulted in 80% reduction hospital-wide in cephalosporin use and 44% reduction in the incidence of ceftazidime resistant Klebsiella. So, formulary restriction and pre-authorization can lead to an immediate and significant reduction in antibiotic use and cost, and it might be beneficial as a part of multifaceted response to a nosocomial outbreak or infection. But the long term benefit effect of this pre-authorization is not very clear. This policy may simply shift one antibiotic to an alternative agent, because that second agent might be used more frequently now in the intensive care unit, what is called squeezing the balloon phenomenon. So, the pre-authorization policy should ideally be coupled with monitoring the overall trends in antibiotic use to assess response and to respond in the shift in the use of these antibiotics. Overuse of one antibiotic might be a result of underuse of another antibiotic. This is an example of antibiotic restriction form. There are certain antibiotics like polymyxin, colistin, daptomycin, tigecycline, which are restricted and requires pre-authorization. Now, what are the supplemental strategies for antimicrobial stewardship? First and foremost is education. Like this talk that I am giving to you, there can be conference presentations, student and house staff teaching sessions, guidelines, education handbooks, laminated cards, email alerts, and so on. But education alone, without incorporation of active intervention, is only marginally effective and has not demonstrated a sustained impact. Guideline implementation can be facilitated through provider education and feedback on antibiotic use. Now, guidelines and clinical pathways like one by the Infectious Disease Society of America, there can be national guidelines, there can be local guidelines depending upon the local antibiogram, there can be evidence-based practice guidelines. There has to be a hospital policy on each hospital depending upon the patient type and the kind of antibiogram and the antibiotic resistance pattern in that hospital. Now, antimicrobial cycling and scheduled antimicrobial switch is, as we mentioned, is an antibiotic cycling, which might not be very beneficial. It might lead to overuse of one antibiotic and underuse of other. It has been found that controlled heterogeneity, as has been practiced in many ICUs in our country, might minimize antimicrobial selection pressure, because there is a simultaneous mixed use of different antimicrobial classes in a heterogeneous fashion, which may slow the spread of resistance. An antimicrobial order form is a must for all intensive care unit. It decreases antimicrobial consumption in longitudinal studies through the use of automatic stop orders. This is a formulae for the antimicrobial order form, but just having the form does not suffice. We have to audit this antibiotic order form. For example, in this audit, only 50% of the forms were correctly filled up. Computer surveillance and decision support system and physician order entry has become a mandatory in all the Western ICUs. It decreases medical error. It gives a pop-up for antibiotic side effects, drug interactions, and it also linked with microbiology lab can tell us whether the antibiotic prescribed is appropriate for the microbiology of that patient. So, computer physician order entry system with integrated decision support system substantially improves patient safety. There is a huge role of microbiology lab in this antimicrobial stewardship. They should do routine susceptibility testing. The clinical microbiology lab should be actively involved in resistance surveillance. Local antibiogram with pathogen specific susceptibility data should be updated at least annually. And there should be a monitoring of process and outcome measurement, a quality control issue. These programs must establish process and outcome measures to determine the impact of antimicrobial stewardship on antimicrobial use and resistant pattern. We should know how much antibiotic are we consuming in our ICU, and a defined daily dose, that is a formula to standardize the dose calculated of the antibiotics that is being used in the intensive care unit should be done. And it is recommended so that hospitals can compare their antibiotic use with that of other similar hospitals. The formula for antibiotic consumption is defined daily doses divided by total number of patient days. And this defined daily dose, WHO has got a very standardized formula which is available on the net. Each antibiotic has a defined daily dose, and depending upon the grams of that antibiotic used in an ICU, that can be converted into DDD, and the denominator will be number of patient days. And this can be compared with national nosocomial infection surveillance data or the developing country data in the INIC. And each hospital should keep a trend of their DDD per 1000 patient days and should compare with their other peers and benchmarking. So, an effective antimicrobial stewardship requires a multidisciplinary team approach that incorporates core strategies and supplementary strategies. The core strategies are prospective audit and feedback to the provider, and pre-authorization and formulary restriction. The supplemental strategies being having an antibiotic order form, having an antibiotic policy, and education. But education alone is not enough. Consensus building with the support of administration and local providers is essential, with the focus on collaborating in the safety and care of their patient rather than a policing role. There are barriers to antimicrobial stewardship program, especially in our country. We do not have lack of properly trained personnel like ID physician, clinical pharmacist, clinical microbiologist, or hospital epidemiologist. There should be enough budgetary provision by the administrators. There is lack of accountability by the prescriber. That is not good. There should be reimbursement for stewardship team, and there is lack of computer surveillance and heterogeneity of healthcare delivery. What are the future direction in this antimicrobial stewardship program? We need more outcome data. We need a patient-centered outcome data of decreasing morbidity and mortality if this teamwork is being implemented. We require easier implementation policies. We require participation of all stakeholders in this program. The environment should be more important, and regulating the environment is equally important. There should be therapeutic drug monitoring of most of the important antibiotics, and with the advent of telemedicine and expansion of telemedicine, this is an area which can be used very efficiently in very remote hospitals for antimicrobial stewardship program. I thank you for your kind